Everybody, I'm Dr. Himanshu Mathur. I'm working as an assistant professor in the Department of Physiotherapy, Jaipur University. And here I welcome you on behalf of Jaipur Rehab for the second part of the biomechanics of the shoulder joint. So last part में हम लोगों ने जाना बहुत significantly और बहुत ही efficiently हम लोगों ने जानने की कोशिश की कि किस तरीके से ग्लिनोह्यूमरल जॉइंट के बारे में काइनेमैटिक्स वर्क करती है उसकी, और कुछ फोर्सेस के बारे में भी जानने की कोशिश की। हम लोगों ने सॉफ्ट टिश्यू स्ट्रक्चर्स के बारे में भी जानने की कोशिश की, लिगामेंट्स के बारे में जानने की कोशिश की। आइए अब हम देखते हैं, देयर आर फ्यू अदर जॉइंट्स व्हिच आर आल्सो इन्वॉल्वड इन द शोल्डर कॉम्प्लेक्स। हम उसके बारे में, स्ट्रक्चर के बारे में जानेंगे, उनके सॉफ्ट टिश्यू स्ट्रक्चर्स या काइनेमैटिक्स के बारे में जानेंगे, और जानेंगे काइनेटिक्स ऑफ द शोल्डर कॉम्प्लेक्स एंड ऑफ कोर्स द ग्लिनोह्यूमरल जॉइंट। So without losing any time, I must start sharing my screen. And here I go. So मेरा introduction मैंने दे ही रखा है आप लोगों को, जो कि इतना important नहीं है. So I'll directly switch on to the thing which I'm working on today. चलिए जी. So the joints which we'll be talking about today will be including the sternoclavicular joint, they'll be including the acromioclavicular joint and the scapulothoracic joint, and of course the kinetics associated with them. Okay. So the first joint today that comes is the sternoclavicular joint, that comes over here somewhere, right? So the articulation is between the medial end of the clavicle and the lateral end of the manubrium sternum, right? तो हम एक बार बिल्कुल गौर से इस बात को समझ लेंगे that it is a classical example of the saddle variety joint. Saddle variety मतलब आप यहाँ पे देख सकते हैं बड़ी easily that दोनों ही आर्टिकुलर सरफेसेस पे कनकेव सरफेस भी है और कन्वेक्स सरफेस भी है, राइट? सो यू मस्ट नोट दिस. अगर आप देखेंगे तो ये जो ट्रांसवर्स डायमीटर है मनुब्रियम स्टर्नम का वो कनकेव है, और लॉन्गिट्यूडल डायमीटर जो है वो कन्वेक्स है. उल्टा हो जाएगा यहाँ पे कि ट्रांसवर्स डायमीटर जो मीडियल इन क्लाविकल का है वो है कन्वेक्स, और लॉन्गिट्यूडल डायमीटर जो है उसका वो है कनकेव, राइट? तो अभी हम जानेंगे काइनेमैटिक्स के दौरान कि कौन सा मूवमेंट जो होता है किस तरीके से अकर करता है यहाँ पे, राइट? सो लेट अस सी क्या लिखा है यहाँ पे. So it is a joint between the medial end of clavicle and the superolateral aspect of the manubrium sternum. Now it links the upper extremity directly to the thorax, right? It is a link between the axial skeleton and the appendicular skeleton. जैसे कि लोअर लिम्ब के समय हम लोग एसआई जॉइंट देखते हैं, तो बिल्कुल एसआई जॉइंट की तरह से ही एक ही जॉइंट होता है कि किस तरीके से एक्सियल स्केलेटन का जो फोर्स है वो अपेंडिकुलर स्केलेटन पे जाएगा, तो उसके बीच का एक की लिंक होता है अपर लिम्ब में, दैट इज योर स्टर्नोक्लाविकुलर जॉइंट. स्टर्नोक्लाविकुलर जॉइंट को स्टेबलाइज करने के लिए तीन स्ट्रक्चर्स मेजरली प्रेजेंट होते हैं यहाँ पे. वो होते हैं, सबसे पहला यू कैन सी इट हियर, कॉस्टोक्लाविकुलर लिगामेंट, इंटरक्लाविकुलर लिगामेंट एंड स्टर्नोक्लाविकुलर लिगामेंट. इसके साथ ही साथ यहाँ पे एक बहुत ही इंपॉर्टेंट स्ट्रक्चर प्रेजेंट होता है दोनों आर्टिकुलर सरफेसेस के बीच में, दैट इज दी डिस्क. आर्टिकुलर डिस्क इज प्रेजेंट. आर्टिकुलर डिस्क का रोल बिल्कुल वही होता है जो दूसरी जगहों पे होता है, दैट इज द अब्जॉर्प्शन ऑफ फोर्सेस, providing better lubrication to the joint, and eventually it works as a shock absorber only, right? Absorption of the excessive forces which are coming over there, right? Now coming on to the different types of stabilizing structures here. So it includes, the first one is the articular disc, which is anterior, posterior, and clavicular and interclavicular ligaments that maintains the joint in position. So first joint that comes, ligament that comes to us is the sternoclavicular ligament. If you can see it here, this one is the sternoclavicular ligament. It eventually blends with the capsule and gives stabilization anteriorly and superiorly moreover, right? Also sometimes in the posterior directions. Okay. Other one is the costoclavicular ligament. It runs obliquely from the medial end of clavicle, a little distal from the articular surfaces, and it gets its insertion or attachments onto the costal cartilages of the first rib, right? So the other ligament that comes over here is the interclavicular ligament. It starts from one clavicle on the left side or the right side, and it goes till the other clavicle, right? It covers the whole superior surface of the manubrium sternum right here. Okay, so this one is the interclavicular ligament also. Okay, so the work of the articular disc is to prevent the medial displacement of clavicle, which is while carrying objects at the side, as well as the inferior displacement of the clavicle via the articular disc, right? So major action is the shock absorbance only and the dissipation of forces while we are carrying objects, while we are performing some strenuous activity. Okay, so this is the basic work of it. So the kinematics that comes to us is, don't start reading it. I would rather like to tell you according to the diagrams that I've told you. But before that, we must know about the osteokinematics of it. So we have three major movements that occurs, or 3 degrees of freedom that are present in the sternoclavicular joint. The first movement that occurs is the elevation and depression, right? It occurs in the frontal plane. The second one is protraction and retraction that occurs in the sagittal plane. And the other one is the axial rotation, right? The axial rotation is just like rotating like this and rotating like this, okay? So you have the total complete rotation of almost 40 to 45 degrees, okay? And that occurs during abduction, that we'll be studying in the later part of today's lecture, right? So the elevation and depression occurs around the anteroposterior axis, and the range of motion is nearly 48 degrees. The total ranges of 48 degrees is present here. Now, if you can see here, whenever we talk about the elevation and depression, the moving surface, the distal articulating surface is the convex shape, right? So the convex axis or the convex surface of the medial end of the clavicle will be working while we are talking about the elevation and depression sort of things, right? If we are elevating and depressing the sternoclavicular joint, the convex shape articular surface will be coming into action, right? And we know that whenever the convex surface moves over the fixed concave surface, the rolling and sliding would occur in different opposite directions, right? So you can see it here very well that during elevation, the rolling is superior and the sliding is inferior, okay? The rolling is superior and the sliding is inferior, that comes over here. And whenever we talk about the depression, it reverses. The rolling is inferior and the sliding is superior, you can see that. So whenever we go into elevation, the sternoclavicular ligament and the interclavicular ligament, they get lax, okay? And the costoclavicular ligaments eventually get stretched. It gets tensed. Opposite happens whenever we come back into depression, the costoclavicular ligaments gets lax, and the sternoclavicular ligament and the interclavicular ligament eventually gets tensed, or they get stretched. All right. Now talking about the protraction and retraction of the joint, it occurs around the vertical axis eventually. So you can call it it can also occur in the transverse plane. Okay. So around the vertical axis, and the total range of motion of protraction is 15 to 20 degrees, and that of the retraction is 20 to 30 degrees. And now if you can see it here in the diagram over here, you can easily recognize one important thing, that this time the axis or the surface which we are talking about is the concave. Okay, so whenever we are talking about the protraction and retraction, the concave articular surface of the clavicle will be moving, right? And we all know that whenever the concave surface moves, then the rolling and sliding will be occurring in the same direction. All right, always remember, when the concave surface is moving, the rolling and sliding will occur in the same direction, right? So whenever you go for retraction, the rolling and sliding will be there posteriorly, and whenever you come back into protraction, the rolling and sliding will be occurring anteriorly. All right, that becomes very easy thing. Okay, so whenever you go for retraction, the costoclavicular ligaments eventually will get stretched, and whenever you will come back for the protraction, the costoclavicular ligament will eventually go for laxity. It will get lax. All right. Moving on to the other important joint for us is the acromioclavicular joint. It is made by the lateral end of clavicle and the acromion, which is the end part of the spine of scapula. Okay, a termination of that. So the important things that we need to see here is, it is an articulation formed by the clavicular facet on the acromion and the acromial facet on the clavicle. It is often described as a plane or a flat joint. It is a plane or a flat joint. That is why only sliding movement occurs in this joint. Okay, so we do not talk about any convex shape or a concave shape variety of the movements that are occurring here. So they are reinforced with superior and inferior ligaments. There are superior ligaments that eventually blend with the muscles like upper trapezius, muscles like middle deltoid and anterior deltoid. So they blend with them, right? There are another ligaments also which are inferior ligaments, and one of the major inferior ligament is your coracoclavicular ligament. Okay, which starts from the coracoid process and eventually gets its attachment onto two different aspects of the clavicle. Okay, so we have two different aspects of the clavicle over here. Sorry, it's not like this, it's this one and this one. Okay, so you have one small tubercle here, you call it as conoid tubercle, and you have one line here that is called trapezial line. Okay, so the ligament which starts from the coracoid process and runs superolaterally, such that it spans obliquely. The ligament, the fibers that spans obliquely and gets its attachment onto the trapezial line, that is known as the trapezoid ligament, and relatively vertical ligament which gets its attachment onto the conoid tubercle, they are known as conoid ligament, right? So we have two coracoclavicular ligament. One is the trapezoid ligament, the other one is the conoid ligament. Now talking about the kinematics, it has internal rotation, external rotation, anterior tipping, posterior tipping. There are a lot of movements which are present here, but now I'll be talking about in context of the whole complex that we'll be talking about, right? And there could be upward rotation and the downward rotation as well. I won't take it this one into too much detail because I'll be taking it with the composite kinematic changes in the shoulder complex, if you can see it here, right? Now what we do is the elevation in the frontal plane, we divide it the whole 180 degrees of range of motion in three phases. That is, the first one is 0 to 90 degrees followed by 90 to 180 degrees, the late phase, and the total one is 0 to 180 degrees, right? So we divide it into two phases. Okay, now whenever I elevate or I take it into abduction, my shoulder, I take it into abduction, first 90 degrees when I talk about. So 25 degrees of elevation occurs at the SC joint, that is in the frontal plane that we studied right now. Okay, so 25 degrees of elevation occurs at the SC joint in first 90 degrees of abduction. At the same time, only 5 degrees of upward rotation occurs at the AC joint. Okay, so always remember, when in the early phase, more movement is occurring at the SC joint, less movement is occurring at the AC joint. In the later phase, it will get reversed. Less movement will be there at the SC joint, more will be at the AC joint, right? So talking about the scapulothoracic joint, there is almost 30 degrees of upward rotation that occurs at the scapulothoracic joint, and 60 degrees of abduction that occurs. We have already studied about the scapulothoracic and the glenohumeral joint, right? Talking about the late phase of the abduction, that is from 90 to complete 180 degrees, right? So 5 degrees of elevation occurs at the SC joint and 35 degrees of posterior rotation at the clavicle. So clavicle also rotate posteriorly whenever I'm going from 90 degrees of abduction to 180 degrees of abduction, right? Similarly, when I talk about the AC joint, I told you it will get reversed. 25 degrees of upward rotation occurs at the clavicle. So it at the initial times 25 here, 5 here. At the later phase, 5 here, 25 here. Okay, so things are getting reversed. Okay, so the movement will get reversed. More movement at the SC joint initially, less movement at the SC joint in the later phase. Less movement at the AC joint initially, more movement at the AC joint in the later phase, right? Followed by 30 degrees of upward rotation at the scapulothoracic joint and 60 degrees of abduction. Okay, so this makes 120 degrees of the whole abduction and 60 degrees of whole upward rotation of the scapula. Eventually 30 degrees of total upward rotation at the AC joint, 30 degrees of elevation at the SC joint, and 35 degrees of posterior rotation at the AC joint. Okay, now this chart makes the picture quite clear over there, right? Now coming on to this is what I needed to tell you. This is the normal situation when there is no movement as such occurring. This is the coracoclavicular ligament, and this is the coracoid process. They have depicted it here, and the clavicle somewhat appears like this because it's a sigmoid shaped bone, right? It's not a straighter bone. Fine. So when there will be more movement here, there will be less movement here. Okay. And whenever this will go for posterior rotation, there will be some upward rotation coming up here. And this upward rotation will eventually cause tension in the coracoclavicular ligament. Okay. So some upward rotation will also be observed here along with the clavicular posterior rotation. And along with that, there is a significant elevation of this medial end of clavicle, right? 25 degrees in the earlier phase and 5 degrees in the late phase, right? So you must always remember this, and this is usually being accompanied by the outward rotation of the scapula. Okay, so it is 30 degrees of outward rotation in the first 90 degrees of abduction, and in the later 90 degrees also there is around 30 degrees of outward rotation in the scapulothoracic joint. Okay, so they've also mentioned that there is a serratus anterior pull that we'll be studying it right now. Now, talking about the static stabilization of the glenohumeral joint. Now, static stabilization, for before we start, I would like to tell you a very few peculiarities about it. That, see, supposingly this is the center of the humerus bone or the humerus head. So you have certain ligaments that run like here. You have certain muscles that runs like here. You have certain muscles that apply some force right here, and eventually right here, and then here. Okay, so there is a constant upward pull being exerted by the contractile tissues also and non-contractile tissues also, right? So we conjointly call them as superior glenohumeral structure or superior capsular structure, because we have capsule over here. So the structures which are present above capsule or superior to capsule, we call them as superior capsular structures, right? So the superior capsular structure, because of the available tension in them, they constantly try to keep a pull. Okay, they constantly try to generate a pull which pulls it against gravity, right? Gravity works like here. This one, Fg, is the thing that works here, and it is pulled by the superior capsular structures, right? There are certain ligaments that are present here. The superior glenohumeral ligament also, there can be acromioclavicular ligament also. So there are certain ligaments that are coracohumeral ligament, I'm sorry. So it is also present over here. So there are certain ligaments that constantly provides you an upward pull. Okay, now let us see what they have written here. So at rest, the superior capsular structures, including the coracohumeral ligament, provides the primary stabilizing forces between the humeral head and the glenoid fossa. So what happens is, whenever the force of gravity is running down here, and the force applied by the superior glenohumeral structures is like here, right? So eventually when we resolve these forces, it occurs somewhere here. So eventually this force pushes the humeral head directly towards the glenoid fossa. Now there is another thing. If you can see, visualize this glenoid fossa. This glenoid fossa is somewhere here. This glenoid fossa is not straight. This glenoid fossa is tilted upwardly to angle of a 5 degrees. हम लोगों ने last class में बात की थी इसकी. So if you draw an angle over here, this angle is of almost 5 degrees, right? So there is a 5 degrees of inclination, upward inclination of the glenoid fossa, which also eventually allows the head of humerus to stay back into towards this glenoid fossa. It doesn't allow it to fall down. Okay, so this can be another issue, or this can be another reason of a good amount of stability. Although when we talk about the geometrical alignment of the glenohumeral joint, it is a joint which is not meant for stability, because you have very small glenoid fossa and a very large head of the humerus. So eventually it does not allow you to go for too much of stability. This joint is basically meant for more mobility and less stability. This is the reason why we require soft tissue structures like glenoid labrum, okay, and a very strong capsule and ligaments which are adjoining here. We require strong support of them. Along with that, we also require strong support of the contractile structures which are present around the joint. So this is the reason why we require so much of supportive structures, so that we can improve and enhance the stability of this particular joint. Right, now let us see what is being written over here. Combining the capsular force vector with the force vector due to gravity yields a compressive locking force oriented at right angles to the surface of the glenoid fossa. This is what I was talking about, right? An important component of the static locking mechanism in the scapulothoracic posture that maintains the glenoid fossa slightly in the upwardly rotated position. That is the 5 degrees of upward rotation position. It is because of the relative position of the scapula. Because in the normal aligned position also, scapula doesn't stay straight. It is in slightly outward rotation. And that slight outward rotation gives an upward rotation position to the glenoid fossa as well. Now, the passive tension within the superior capsular structures is significantly reduced, just a second, is significantly reduced when the scapula loses upward rotation position. Okay, so what happens is whenever the scapula goes into inward rotation or a downward rotation, right? So this 5 degrees upward rotation is eventually lost. If this rotation is eventually lost, these structures which are superior capsular structures, the tension in these structures also reduces. If the tension in these structures reduces, the force because of the gravity would rather predominate, okay, which rather dominate over the forces which are superior capsular structure. So if this gravitational force will dominate, it will eventually pull the head of the humerus out of the glenoid cavity, and it will eventually lead to either subluxation of the joint or the dislocation of the joint. It can lead to, okay. So this is eventually, so this is what I was talking about. So this is the force by the superior capsular structures in this direction. This is because of the gravity, and this is eventually the compressive force towards the glenoid fossa, right? So this thing maintains the static stability. Right now, we are not talking about the exclusively about the contractile structure. We are taking into account the contractile also, non-contractile also, but in the static position. We are not talking about the movements, okay? We are talking about the static position, because the we'll be talking about the movement in the dynamic stabilization thing, right? Now what happens is this angle, if you can see that this angle with the vertical is 5 degrees angle, okay? This is the 5 degrees angle. Now if this angle is lost, if this becomes vertical, the tension occurring because of the superior capsular structure will be lost. Now, if this will be lost, this force will reduce in the magnitude also, and the direction of the force will also get changed. Now, if this will change, eventually this, what you can say, this force will dominate. If this force will dominate, this force will also reduce in its magnitude also, and the direction will eventually change to directly to the center. It will go a little beyond the center, right? So it will try to go into relative inferior positions, right? And these inferior positions will eventually lead to either subluxation of the joint, or the, if it is associated with a trauma or any other sudden force, it might lead to dislocation of the joint as well. All right. So the next thing what we have to talk about here is the muscles of the elevation at the GH joint, that is the glenohumeral joint. Now, if I talk about the muscles in the for the flexion, so you have anterior deltoid which is coming over here, you have biceps which is coming throughout in the bicipital groove, so they'll apply a very strong straighter pressure, right? So they'll be applying a pressure or the force which will be directed superiorly, okay, and eventually inwards, right? So they'll be helping you to go elevate your arm into the sagittal plane. So elevation of the arm through the flexion is performed primarily by the anterior deltoid, coracobrachialis, and the long head of bicep brachii. Okay, so ये सारी muscles जो हैं, they'll help you out to go for a flexion. The line of force of the middle deltoid and supraspinatus is similar during the shoulder abduction. Now, okay, I'll just take the next point and then we'll explain you very important clinical insight. So you have very important two muscles which are coming. One is the rotator cuff muscle, that is the supraspinatus, although it has a very small attachment distal to the glenohumeral joint. And the other muscle is the deltoid muscle, the middle fibers of the deltoid, which eventually inserts at the deltoid tuberosity, and it has a long excursion even after the glenohumeral joint. So this is what is written in the next point is both the muscles have a significant internal momentum that remains essentially constant at about 25 millimeter. That includes around some 1 inch or a little more than a 1 inch throughout most of the abduction. Now, one important thing is that whenever your supraspinatus muscle gets injured, or it gets strained at a higher degrees, or it gets paralyzed, so in that case, your middle fibers of deltoid cannot go for complete range of shoulder abduction. But if in case the middle fibers of deltoid gets injured, or if they get paralyzed in some or the other way, supraspinatus muscle can cause complete or can carry out complete abduction through the whole range of movement, although the torque generated will be lesser as compared to the middle fibers of deltoid, but supraspinatus can do that, right? So it's a very important clinical insight whenever we are treating any middle fibers of deltoid injury patient, if you are treating any supraspinatus tendinitis patient, supraspinatus injury patient, so you can always look into this particular situation, right? Next comes is the posterior aspect of the shoulder joint. We'll be talking about the upward rotation of the scapula, the major muscle that causes the upward rotation of scapula. Or when we talk about the BD choracea thing or the anatomy thing, you'll always know that serratus anterior is the muscle that leads to, that causes the upward rotation. But today you'll get to know a different aspect of it, that it is not only serratus anterior. There are a few other muscles also which helps the scapula to go into upward rotation, right? Now this movement is being carried out by serratus anterior and eventually all fibers of the trapezius. I won't take it as all fibers because middle fibers, although it participates in the movement, but the predominant fibers are the upper fibers of the trapezius, which will work like here, and the lower fibers of trapezius, which will work in this direction. And the serratus anterior will eventually work in this direction, right? So these three muscles make a force couple. If I supposingly keep the axis of rotation which lies at the root of spine of scapula somewhere here, so you can depict the directions of the upper trapezius like here, you can depict the direction of lower trapezius like here, and the serratus anterior like here. The directions are like that. Okay, it resembles eventually the if you have seen the gates present in the garden, if you have seen the rolling gates in the gardens, also in the hotels also these days, and a lot of places where you just have to roll one fly of that particular gate, and the complete gates rolls around, and then you get in or get out of that particular gate, right? So it resembles this particular thing over here. All right, now let us see what they have to say. The axis of rotation for the upward rotation of the scapula lies onto the root of spine of scapula, that I've already told you, somewhere here. These muscles forms a force couple, and the lower traps particularly has shown to have a greater electrical activity during the last phase of abduction. Okay, so in the last phase of abduction, that is 90 to 180, or eventually I would take it as from 120 to 180 degrees, it has shown to have more electrical activity, but it has shown more electrical activity in eccentric manner. Okay, because the scapula is going out, so there will be more of the what you can say, the eccentric work which is being done by the lengthening work which is being done by the lower trapezius muscle, which eventually allows the scapula to go into outward rotation. Okay, so this is something what I was telling you. So these are the force of direction for the upper trapezius, this one by the lower trapezius, and this one by the serratus anterior. Fine. So this is the gate I was talking about. Serratus anterior applies force like this, like this. This is by the lower trapezius, this is by the upper trapezius. So this is how you can roll up the gate. Now the gate is your scapula, right? So you are eventually doing this and doing this. Okay, so this particular motion is being observed by the force couple, the three movements, and the middle fibers of deltoid and supraspinatus eventually will be working to pull your humerus into elevation, into the abduction. Now the regulators of dynamic stability in the glenohumeral joint. We have to talk about the dynamic stability of the joint as well while we perform any such movement. Although we have already talked about a lot about the abduction movement stability by the force couples. Now the anatomic design of the glenoid cavity, that is the upward rotation, right? The elevation of the glenoid cavity allows more mobility than stability. An essential function of the rotator cuff is to aid for the stability, right? If you can see that these three muscles are all the part of the rotator cuff. Eventually, we are not able to see the subscapularis muscle, and that also helps in the stability only. So the supraspinatus, the force of direction of the supraspinatus is like this, because this is the supraspinous fossa. This is the infraspinous fossa, and the muscle which is coming here is the infraspinatus, followed by the teres minor, a small teres minor muscle also coming over here. So the forces of rotator cuff muscle not only moves the humerus into abduction, but also stabilizes and centralizes its head against the glenoid fossa. Now I'd like to tell you one important thing, because they are also telling about the active controllers of the arthrokinematics in the GH joint, which is very important thing to talk about, is the contraction of the just a second. The contraction of the horizontally oriented fibers of the supraspinatus produce a compressive force directly into the glenoid fossa. We have already talked about. So they are almost horizontally placed fibers. So they are eventually pulling the head of the humerus directly into the glenoid fossa. Okay. Now this force keeps the head stabilized during the superior roll. Now, if there is a constant force which is pulling my head directly inside, it will try to keep my head stabilized and it will not allow it to slide down or go into any sort of subluxations or any sort of instability. So this one muscle is primarily working for stability of the head of humerus during the whole abduction movement. Okay. Now, compression between the joint surface increases linearly from 0 to 90 degrees of the shoulder abduction, reaching a magnitude of 90% of the body weight. So whenever I perform movement 0 to 90 degree, the compressive loading that occurs in the articular surface eventually reaches to the 90% of the total body weight. See, suppose if I'm 100 kgs of weight, almost 90 kgs of a force that equalizes 90 kgs would be present between my shoulder if I am taking it into 90 degrees of abduction. Okay. The surface of dissipating joint surface forces increases to a maximum between 60 to 120 degrees. अच्छा, अब 0 to 90 डिग्री में से भी 60 से 120 डिग्रीज का जो मोशन होता है, इसमें हमेशा जॉइंट सरफेस जो होती है, जो जॉइंट आर्टिकुलेशन होता है, वो हमेशा मैक्सिमम होता है. इसी वजह से यू कैन इवेंचुअली डिसिपेट द फोर्स इक्वली. क्योंकि जो फोर्स वर्क कर रहा है दैट इज इक्वल ओनली, और जो एरिया है वो बढ़ रहा है. इवेंचुअली इट इज लोअरिंग डाउन द प्रेशर दैट इज अकरिंग इंट्राआर्टिकुलरली. So because pressure is equals to force per unit area, so if the area is increasing, the pressure is eventually getting lower down. So जब pressure lower down हो रहा है, तो any sort of degenerative changes are being prevented. ठीक है ना, क्योंकि articular surfaces पे degenerative changes जो आ रहे हैं वो हम किसी ना किसी तरह prevent कर सकते हैं, because we are lowering down the pressure by increasing the surface area. Okay. So it is again a clinical insight for any sort of strengthening exercise. You can choose 60 to 180 degrees of motion, right? अच्छा, 60 to 180 डिग्रीज ऑफ मोशन की अगर हम बात करें तो एक और इंपॉर्टेंट बात मुझे याद आती है, जो कि होता है पेनफुल आर्क सिंड्रोम, जो कि बहुत कॉमन होता है इंपिंजमेंट सिंड्रोम्स में. ओके, तो नाउ अब हम बात करेंगे इस चीज की. इसके बाद मैं आप लोगों को बताऊंगा जो चीज मैं आप लोगों को बताना चाह रहा था, क्लिनिकल इंसाइट जो होती है, इंपॉर्टेंट क्लिनिकल इंसाइट, इसी डायग्राम पे बताऊंगा मैं. नाउ विदाउट एडिक्वेट सुप्रास्पिनेटस फोर्स, the near vertical line of force of a contracting deltoid tends to impinge the humeral head superiorly against the coracoacromial arch. ठीक है ना, thereby blocking complete abduction. अब हुआ ये कि जो डेल्टॉइड है, डेल्टॉइड ने इसको ऊपर पुल करना शुरू किया. अब ऊपर पुल करना शुरू किया तो ये हेड भी ऊपर पुल होता चला गया. अब हेड अगर ऊपर पुल होता चला जाएगा तो यहाँ पे है अपने कोरैकोएक्रोमियल आर्च, और इससे जाके स्ट्राइक कर जाएगा, ऊपर जाके टकरा जाएगा, और जो भी स्ट्रक्चर्स बीच में होंगे वो इंपिंज हो जाएंगे, राइट. तो यहाँ पे काम आता है आपकी दो मसल्स का. इवेंचुअली यहाँ पे नाम दिया हुआ है सिर्फ सबस्कैपुलरिस का, लेकिन सिर्फ सबस्कैपुलरिस नहीं होती है. Subscapularis, it is from the anterior aspect of the scapula, and infraspinatus from the posterior aspect of the scapula. So पीछे से जो infraspinatus है, it is also applying a force in the same direction, right? डायरेक्शन भी सेम है और मैग्नीट्यूड भी सेम होता है. तो क्या होता है, जैसे ही इसको ऊपर ले जाने की कोशिश करता है, these two muscles eventually apply a downward force on the head of the humerus. अगर ये दो मसल्स डाउनवर्ड फोर्स अप्लाई कर रही हैं हेड ऑफ द ह्यूमरस पे, तो यही रीजन है कि जब मैं अबडक्शन करता हूं तो हेड ऑफ द ह्यूमरस स्लाइड्स इंफीरियरली, क्योंकि सुपीरियर रोलिंग का काम तो डेल्टॉइड करा रही है. अगर डेल्टॉइड सुपीरियरली रोल करा रही है मेरे हेड को, हेड ऑफ द ह्यूमरस को, तो सबस्कैपुलरिस और इंफ्रास्पिनेटस जो दो मसल्स हैं वो नीचे खींच रही है. इट इज पुलिंग डाउन द हेड ऑफ द ह्यूमरस, एंड दिस पुलिंग डाउन इवेंचुअली इज कॉजिंग द inferior sliding of the humeral head during the abduction movement. Okay, now during frontal plane abduction, the infraspinatus and teres minor muscle can rotate the humerus externally in order to increase the clearance between the greater tubercle and the acromion, क्योंकि वहां पे भी impingement होता है. तो हुआ क्या कि अगर मैंने internal rotation से शुरू किया तो शायद मैं complete range नहीं ले जा पाऊंगा, मुझे shoulder का elevation करना पड़ जाएगा. Okay, क्यों? क्योंकि जो greater tubercle है, it will strike the coracoacromial arch, okay, or the acromion eventually. So to clear off the greater tubercle, I'll be rotating my shoulder externally. जिससे कि जो gated tubercle होता है वो क्लियर हो जाएगा. It will clear the coracoacromial arch or the acromion, and अगर वो क्लियर हो जाएगा तो I can easily rotate it to complete range of motion of 180 degrees. Okay, so this was all about today's class on to the biomechanics of the shoulder joint. Just a second. And just a second. Okay, so this was all about today's meeting of the biomechanics of the shoulder joint part 2. I hope आप लोगों को के लिए clinically insightful रहा होगा, academically and biomechanically भी insightful रहा होगा आप लोगों के लिए ये चीज. If you have any more questions that are coming your way, you can come to me and talk about any sort of things. You can talk to me on WhatsApp, you can talk to me on email, you can talk to me on Telegram, you can talk to me on Instagram, you can talk to me on Facebook, talk to me on call, anyhow. If you have any questions, you can directly contact me and I'll be very happy to resolve your queries. Although हमने बहुत ज़्यादा इसको simplify कर दिया है इस चीज़ को, so that you can understand the biomechanics of the shoulder joint. नेक्स्ट वीक जो है हमारा नहीं रहेगा इस चीज का, बिकॉज उसके इवेंचुअली बिल्कुल नेक्स्ट डे पे आरपीएससी का एग्जाम है. तो वो आरपीएससी का एग्जाम के लिए हम लोग नेक्स्ट संडे के लिए इसको एक संडे गैप दे रहे हैं. उसके नेक्स्ट संडे विल बी कंटिन्यूइंग विद द बायोमेकेनिक्स ऑफ द एल्बो जॉइंट. लेकिन आई मस्ट टेल एवरीबडी वन थिंग, दैट वी आर कमिंग अप विद free sessions of the paper solving and other doubt solvings of during the for this particular thing, RPSC and other competitive exams also. मेरे पास बहुत ज़्यादा queries आई थी कि please start for the AIMS exams also, and इसीलिए we have come up with we have joined hands with Target Ortho, and we'll be starting the classes very soon for the competitive exams also. हम लोग RPSC के लिए भी करेंगे in next few days. That will be starting from Wednesday. So Wednesday, Thursday, Friday we'll be talking about the RPSC thing, and uske baad we'll be continuing it for the other competitive exams also. So we'll be going for paper solvings of AIMS and the other various exams which are happening in the whole country. We'll be going for the mock paper presentations. We'll be having doubts resolving classes. We'll be having various other important topics that will be covered in those particular sessions, right? So thank you so much everybody for joining today. I'll be taking leave for today. Thank you so much. Stay tuned, stay connected for various different projects. We are also coming with some different cardio and sports project very soon. So please stay connected with us. I think that will be quite insightful and knowledgeable for you. Thank you so much. Stay home, stay safe. Thank you.